Great, thank you. Welcome, everyone. Thanks for joining us today. My name is Kevin Haggerty, and I'm at the University of Alberta. And given that many of us are sort of spread in many different locations, I thought it would be good for maybe me, who is in Edmonton, to start us off in a good way with a land acknowledgement. And University of Alberta acknowledges that we're located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. Great, and welcome again. We're very privileged today to have Dr. Amanda Butler to speak to us, and she is from Simon Fraser University. I think many of us know her work. She is a mixed method scholar, works with different types of data sets. She's interested in improving the outcomes for justice-involved people who have mental health and substance use disorders, and this includes interest in drug policy, criminal justice diversion. And today, the title, unless it's changed, the title I have is Opioid Toxicity Deaths Among People Who Experience Incarceration and the Impact of COVID on Death Rates. So assuming that's where we are, thank you very much. I look forward to this. For people who may be kind of new to this, we will have an opportunity for questions at the end. If you're joining us on the Zoom, you can just post a question or comment on the Zoom, and that'll get relayed to me, and I will pass it on, or you can wait and make a comment on Zoom. So thank you very much. So Amanda.
Great. Thanks so much, Kevin. Hi, everyone. Thanks for having me. I'm really privileged to be here. I'm calling in today from the unceded and ancestral territory of the Coast Salish people here in Vancouver, British Columbia, so the lands of the Musqueam, Squamish, and Tsleil-Waututh First Nations. But all of the work that I'm going to be presenting on today is actually based in the province of Ontario, which is effectively where I did my postdoc, although I did most of it remotely from here in BC. From the unceded and let's see what's going on here. There we go. So I have no conflicts to declare, and the work that I'm going to share with you today was all funded by the Canadian Research Initiative in Substance Matters, or CRISM. And the principal investigator on all of these studies is Dr. Fiona Kiumjan, who's based in family medicine at McMaster University in Ontario. And as I said, most of this work was completed as part of my postdoc, and I'm now an assistant professor in the School of Criminology at SFU. And I'm also happy to sort of just like take questions throughout. I'm not sure if you have a structure you prefer for me to just go through everything and then answer questions, but I'm okay with this being a bit informal. It's just that I can't see most folks. So if someone else can just sort of like moderate or let me know if somebody is jumping in as I'm talking, that'd be great. So I'm going to start out by just giving a bit of a background and context. None of it that will probably be new to most of you, especially any of you who are doing work in drugs or drug policy area. And then I'm going to talk about findings from a few different studies. The first is just focused broadly on the burden of opioid toxicity among people who experience incarceration in a 5-year or 6-year time period, as well as looking at the impact of COVID-19 on opioid toxicity deaths among people who experienced incarceration in Ontario, and opioid toxicity deaths among people who are Black and Indigenous. But this is a bit of a lie because I'm actually only going to share the results for the study that focuses on people who are Black. The results for folks who are Indigenous are currently under review. So I'm actually not going to share them today, but I hope that I can share them soon. So there's been a bit of international work on mortality among people who experience incarceration. So just to sort of set the tone, this is a graph from a study conducted by Rowan Borshman, who's an Australian scholar, but now based in the United Kingdom. This is from the Merrick study, and so uses data from countries all over the world. And this is rates and causes of deaths after release from incarceration, an individual participant meta-analysis from a whole lot of people. It was published recently in The Lancet. So I show this just to show that it's sort of across the board, that what they say AOD. We don't usually use that term, but alcohol and other drug poisoning is sort of a leading cause of death among people who experience incarceration, and tends to be highest and most elevated in this sort of immediate post-release period. So you can see in sort of, I guess, the dark blue there, the point estimate as well as the confidence intervals, and for the AOD poisoning, which does sort of attenuate over time, but is particularly stark at the beginning, but it tends to be elevated even after folks are released, many weeks and months after people are released from prison. It continues to be the most common cause of death. I'm sure that most of you are familiar with the opioid crisis that we're in. It's, we're talking about that a lot, particularly here in BC, but it's a problem obviously all over the country. So opioid toxicity deaths have increased substantially between 2015 and 2020, which is the time period of our study. And in Ontario, there are currently about 2,500 to 3,000 opioid toxicity deaths per year. And one of the leading causes of that is fentanyl. So for those who are not aware, fentanyl is a synthetic or man-made opioid that works a lot like morphine. It's 100 times more potent than morphine and 50 times more potent than heroin. We also now have carfentanil in the drug supply, which is approximately 10,000 times more potent than morphine and 100 times more potent than fentanyl. And it's currently the case that fentanyl contributes to roughly 90% of accidental opioid-related deaths in Ontario. And that's a 600% increase between 2016 and 2021. So we're definitely in a crisis situation. And so I think the value of our study is looking at what we're calling the fentanyl dominant period. So there have been a few studies that have looked at mortality after release from prison, but we're in a pretty unique time period given what's happening with the opioid toxicity crisis. So in terms of what we did for this study, actually the 3 studies that I'm going to be talking to you about today, we linked and analyzed data that we got from the Ministry of the Solicitor General in Ontario for all people who were detained or incarcerated in the province in a provincial correctional facility between 2015 and 2020. And we linked those data with data from the Office of the Chief Coroner of Ontario for all people who died from opioid toxicity between 2015 and 2020, which was 8,460 people. And we used data from the Statistics Canada census to calculate general population rates. So census data for age and sex were interpolated to estimate the population from 2015 to 2020. And we assumed that all people in what we're calling the unexposed groups, that was people who were not exposed to incarceration, contributed 1 calendar year per year, contributed 1 year of person time per calendar year. And for what we're calling the exposed group, which is people who experienced incarceration, they entered the exposed group from the date of their first incarceration during the study period, and then contributed person time to the exposed group, whether or not they were in custody. So this is like a bit of an important methodological distinction. As soon as they enter the exposed cohort, they stay in the cohort. So even if somebody was incarcerated for, say, a few months and they were released, they're considered part of the exposed group. So we're not just looking at whether people died when they were in custody, we're looking at incarceration as an overall exposure during the time period. So if anybody has questions about that, you can let me know. I think it's a little bit weird to sort of get your head around, but nonetheless, they remain in the exposed group, whether or not they're in custody or they're in community. And like I said, we access data from the Office of the Chief Coroner for all opioid deaths. In Ontario, there is a legal obligation to report to the coroner any death from opioid toxicity, which can include sudden and unexpected deaths where opioids were identified in post-mortem toxicology and were determined to have contributed to the cause of death, either alone or in combination with other substances. So it didn't have to be opioid toxicity alone, could have been in combination with methamphetamine or other drugs, but opioid had to have been identified as a contributing factor in the coroner's data. To support interpretation of the study, we also conducted some knowledge exchange sessions with 14 people with lived experience of incarceration in Ontario and substance use, or family members of people who had incarceration and substance use experience. So I'll tell you a little bit about the first study that we published in BMJ Open, which just sort of looks overall at the burden of opioid toxicity death in the fentanyl dominant period. So in terms of our study aims, it was to calculate the number of people who experienced incarceration who died from opioid toxicity and describe their characteristics, as well as estimate and compare the rates of death for people who experienced incarceration to others in the general population. So remember the general population, we got those data from Statistics Canada from the census. So in terms of our first question, how many people were incarcerated between 2015 and 2020 died from opioid toxicity? So of the roughly 130,000 people who were incarcerated in Ontario during that time, 2,207 of them died from opioid toxicity during the time period, either while they were incarcerated or after release, which is just shy of 2% of the total incarcerated population. And we also asked how many people who died from opioid toxicity had any provincial incarceration. So it's answering sort of the same question, but in a different way. So we found that there was a total of 8,460 people all over who died, and 2,207 of them had been incarcerated. So what that means is that over a quarter of all people in that time frame who died due to opioids, more than a quarter of them had experienced at least one incarceration during that time period. And 1 in 6 of them, so just roughly 16%, had been in provincial custody within the 1 year prior to their death. So remember how I said that once you enter the cohort, you stay in the cohort. So that means that technically you could have died 3 years later, could have been 4 potentially, because our time frame is 2015 to 2020. But a good chunk of those people, well over half, died within the year of their release. So here's a table just showing generally some of the characteristics of people who experienced incarceration and died from opioid toxicity. So what you can see is that in terms of the age groups, more than half were aged 25 to 39, and the vast majority were between the age of 25 and 49. And then the smaller age groups are on the youngest age, 18 to 24 or over 50. The vast majority of people who died were male, but that also is reflective of the proportion of men who are incarcerated in comparison to women. So fewer than 15% of the provincial custodial population are women. It's mostly men. And in terms of people who died, they tended to have more overall incarceration episodes. So people sort of cycling through provincial custody. So in terms of our third question, we asked, how does the risk of death compare for people who experienced incarceration and people who did not? So this is where we conducted standardized mortality ratios using age adjusted data from the general population and expected deaths compared to how many deaths actually occurred. And what we found is that the risk, although the number of men is much higher, the risk for women when you compare to the non-incarcerated population is much higher. So for women, the risk was 78 times higher, and the risk for men was 28 times higher compared to people who did not experience incarceration. So here is just a bit of a better breakdown. So we've got the opioid toxicity death rates per 100,000 person years among people who were incarcerated and people who were not. And then we've got the crude opioid mortality rate versus the age standardized. So overall, it's very high, roughly 31. terms of the age standardized mortality, but I think it's really important to look at the sex differences because women have a much higher relative risk compared to people who don't experience incarceration. So we also looked at whether the risk of death varied, whether the person was in custody or what period they were in their post-release term. And what we found is pretty consistent with what Dr. Rowan Borschman and others have published, which is that the highest risk period is in the immediate time that the person is released. So really within the first week to 2 weeks is where you see the highest risk. Although again, the number of people who die could be much further down the road. So the way that this graph works is the first piece there is deaths in custody. 58 people in total died. And so in terms of the overall rate, that's the lowest. So I'm hesitant to say that like being in custody is protective, but there are mechanisms by which people are somewhat protected in a custodial environment from death by virtue of how the custodial environment is structured. However, there is a risk associated with experience incarceration because when people are released, they're at very high risk of death. So we have in the graph both the numbers, the total number of people who died, as well as the rate per 100,000 person years. So this is a graph which just basically looks again at the period of incarceration versus period after release from custody and people who died in custody. So as I said earlier, 26% of all deaths occurred among people who experienced incarceration. Almost 16% occurred within the past year of their incarceration, 7% in the past 3 months, 4% in the past month, 2% in the past week, and then the lowest number is people who died in custody. And again, this is obviously just among people who experienced incarceration. So in addition to the linked data analysis, we conducted some knowledge translation and exchange exercises with 14 people who had experienced incarceration and some form of substance use. Most of the people did report using opioids, but many other things as well, and family members. And some of the things that they told us is that there's obviously a desperate need to address the criminalization of people who use substances, not just relative to simple possession, because for most folks, they weren't actually going to custody for the possession of drugs, but because there are a lot of other ways in which people who use drugs are criminalized, the criminalization of poverty, so many sort of like intersecting vulnerabilities that people who use drugs experience. And so they talked about the need to address those factors. They also told us that there's a need for enhanced treatment as well as harm reduction in custody. So we heard from folks that had been incarcerated at different locations that access to care, access to things like opiate agonist therapies were highly variable depending on where they were in the province. The wait times to treatment initiation varied. So in the province of Ontario, unlike in BC and also, I believe, Alberta, the health service delivery within custody is still under the Ministry of the Solicitor General, whereas here in BC, health service delivery is delivered by the Ministry of Health. And so there are, of course, complications in terms of continuity of care, continuity of medication, both when people are admitted to custody as well as when people are released. Something that came up very unsurprisingly was housing for everyone. That's a major issue, is that folks don't have safe places to go after release. Many people are released to homelessness or to very precarious situations, possibly to emergency shelter locations. And so even for people who expressed that they had a desire to continue with sobriety or not to use, they were often put in environments where they were exposed to drug use, and many of them continued to use drugs after release. And so really supporting that continuity of care is really important. as well as addressing many other factors like mental health issues, addressing the stigma associated both with substance use and incarceration experience, as well as the need to implement sex and gender specific approaches. So we heard a lot from the women that, they have extensive experiences of intimate partner violence. Some of them talked about their drug use actually often being sort of managed and dictated by an intimate partner. Some of them also discussed like not being able to access what for them was a safe and trusted supplier because of going into incarceration and then not having that after release. So these were some of the things that they shared with us about their experiences and things that we might want to address to help mitigate some of the risks associated with experiencing incarceration. Okay, so I'm going to talk a little bit now about another study that we did that looked at the impact of COVID-19 on deaths using the exact same data set. So I won't go over that part again. And this one was published in PLOS One. So we know that COVID-19 has been associated with increases in substance use and drug-related deaths across North America. Several people have published on that. And although we don't know for certain, there are some proposed mechanisms associated with this relationship. So things like restrictions that decrease service capacity and availability. We also heard about that in our consultation. So people not being able to receive sort of in-person services, reduce capacity within those services, border restrictions that may have contributed to a more volatile drug supply, as well as all of the other things associated with COVID-19 stress, social isolation, worsening mental health, being told to isolate. And so the continuation of pre-pandemic trends and rising synthetic opioids deaths does make it difficult to assess the precise contribution of the pandemic to rising deaths, which is like partly what we wanted to be able to do with our data. So the overall aim of this study was to estimate the impact of COVID-19 pandemic and related restrictions on toxicity, mortality in custody and post-release, and then to compare with people who did not experience incarceration. So in order to do this, we used an interrupted time series analysis where COVID-19 was treated as an event that occurred on April 1st, 2020. So the reason why we chose April 1st, 2020 is because it was the start of the month where a number of pandemic restrictions had been officially implemented within the province. So it was like late March that they made this decision. And so we looked at the number of opioid deaths and time at risk calculated by month, and the rate of death was calculated as the number of deaths per 10,000 person years at risk, so similar to the previous study. And we conducted a multivariable negative binomial regression analysis with our explanatory variables being age group, sex, exposure to incarceration, so yes, no, the month, and then COVID-19 being treated as an event on April 1st. So what we found was that COVID-19 immediately and substantially exacerbated the risk of opioid toxicity death for people who experienced incarceration, but did not change the rate of the increase over time. So with the interrupted time series analysis, it looks at changes in both the level as well as the slope. We found significant differences in the increase in risk between people exposed and not exposed, as well as differences by sex, which we sort of predicted would happen. The level changed significantly, and furthermore, the level depended on sex and exposure to incarceration. And the regression analysis found no significant impact of COVID-19 for females who were not exposed to incarceration. So in terms of the panels, what you can see here is at the top is people who were not exposed, with females on the left and men on the right. And at the bottom, females and males. And then on the bottom is our exposed groups of people who experienced incarceration. And what we're looking at is our risk ratio relative to, we needed to pick a reference group. So our reference group is men aged 18 to 24 in January 2015, which was just the first month of our study. And what you can see is that the patterns across all of them in terms of the age groups are the same, but there's very distinct differences by sex and by exposure to incarceration. So for men who were exposed to incarceration, we saw a 50% increase associated with COVID in terms of death. For females who were exposed to incarceration, there was a 21% increase. And then in the unexposed group, there was a 25% increase for men, but no significant differences for women. In all cases, people who were between age 25 and 39 had the most significant increases, followed by people in the 40 to 49 age group. As part of this paper, we also performed a segmented Cox proportional hazard survival analysis using what's called a counting style approach to determine whether the death rates within our exposed group, so among people who experienced incarceration, changed based on the period post-release, or whether that association changed over time. So remember how we had said before that we're interested in the point at which people die. For this analysis, we're looking at whether that risk changed over the time period. So we had people grouped into either in custody or in community. And then with the in community group, so these are people who have been released from custody, they were further categorized by being within the first month, being within 31 to 200 days, being within 201 to 365 days, or more than a year. And what your status is could change over time. So basically, while a person was either incarcerated or in community, a new time segment started every 30 days. And each time segment was given for a person who is characterized by their sex, their age, and start of the time segment by incarceration or community status. Which sounds kind of confusing, but basically, if you were in community, say at the start of a 30 days, and then partway through you became incarcerated, your status would start over again. So any change in and out of community would restart the clock to another 30 days. And we're just doing this counting over the whole time period to see whether the risk changed over the time period. So what we found was that people had the lowest risk while in custody. And then using the period of custody as the reference group, the risk in community was highest during 1 to 30 days, which again, not surprising based on our first analysis, with a hazard ratio of 12.6. And increasing time spent in community, the risk would decrease. So over the study period, the risk for each of the 4 periods post-release from custody did increase, but it increased by roughly the same amount, regardless of the time spent in community. So basically, although they all increased, there was no particular increase for people in the first 30 days versus 300 to 201 days. They all increased, and we found no significant interaction between the year and the time spent in community. We also found that the interaction between COVID-19 and the incarceration versus community status was not significant, which indicated that we had no evidence that the impact of COVID-19 differed by these different time periods. So COVID-19 increased for everyone. The risk increased sort of across the board, and dividing people by these community times in community didn't change as a result of COVID. And then in terms of the interaction with sex, the sort of annualized increase for men was 1.15, and the annualized increase for women was 1.34. So all of that is to say that we found that COVID-19 immediately and substantially exacerbated the risk of opioid toxicity death for people who experienced incarceration. The differences in risk depended on whether you were exposed to incarceration, and there were obvious differences between females and males. So females exposed to incarceration were at much greater risk compared to females not exposed. And males who were exposed were the most impacted by the COVID-19 pandemic. And we expect, of course, that there's a complex interplay between COVID-19 and the opioid crisis, which has really important implications for future public health emergency preparedness. Okay, the last study, I'm just checking the time here. Are you wanting, Kevin, for me, I'm not sure how long you want me to speak for, so I just want to be aware of the time.
We have a full hour, so you have plenty of time.
Okay.
There will be questions, I'm sure.
Okay, sounds good. So we also conducted a couple of studies just focused on people who are Black and Indigenous. So in 21-22, Black people made up roughly 9.2% of the overall prison population in federal custody, despite making up under 4% of the general population. And many of us obviously know that the figures are very stark for Indigenous people as well, with roughly 30% of the prison population being Indigenous, but making up less than 5%. And that varies obviously across Canada. In some places as high as 80-90% of people in custody identify as Indigenous. So data on opioid toxicity death among people who are Black and Indigenous are summarized in two separate papers, but I am only going to discuss the results of the paper for people who are Black. We do have a paper on people who are Indigenous currently under review in the Lancet Regional Health America, so hopefully I can share that soon. So this is a paper that was led by Dr. Akwasi Owusu-Bempah and was published in Preventative Medicine using the same data that I've been discussing all along. So I won't go over the methods again. This is really similar to what we did before. Of the roughly 17,000 people, or nearly 13% of our population were categorized as Black, and an additional 17,389 people had prefer not to answer unknown. So that is an unfortunate limitation of our data, is that it's self-reported race. And so we did have just over 13% of people who either preferred not to answer or were unknown, and we had no available race data for them. And then the other thing, of course, to mention is that for the census data, we also didn't have race. So this table here just shows observed opioid toxicity mortality for Black people who experienced incarceration in our time period, and people with no incarceration experience in the time period, and then the standardized mortality ratios on the right for males, females, and total. So for males, the SMR was 13. For females, it was 52, and the overall SMR was 17.8. And so this table summarizes some of the same data, but also includes all people who were not categorized as Black. So looking at people who are categorized as Black and all people not categorized as Black. So that includes obviously people who are white, South Asian, and other things. And what you can see is that in comparison to people who were not categorized as Black, people who were Black did not actually have an elevated SMR or elevated rates. However, very elevated in terms of people who did not experience incarceration at all. So the SMRs are still much higher than people who had never experienced incarceration, but among all people who experienced incarceration, the rates were no higher than people who did not identify as Black. And sorry, I should have probably just like highlighted this table so that you can make sense of it. But here's people who are Black. The total SMR, as I said, was 52 for females and 13 for males. And then in terms of people who were not categorized as Black, it was almost 80 for females and 30 for males. We also recognize that mechanisms leading to the increased risk of opioid toxicity deaths among people who are Black may may differ, and incarceration is also a risk factor for death, and we know that people who are Black are disproportionately impacted by the criminal justice system and by incarceration, and also have higher rates of death for other reasons. And so all of these things intersect. Unfortunately, our data don't answer the why questions. They just provide some data around the patterns and things that we need to be paying attention to. So in terms of just kind of key findings overall, we confirmed, as other studies have, that people who experience incarceration are at very high risk of opioid toxicity death. And the highest risk is really at the time of release and in the immediate days and weeks after somebody is released. We know that this risk is, in fact, getting worse over time, and that people who experience incarceration were disproportionately impacted by the COVID-19 pandemic for, I'm sure, a whole host of reasons. So there's certainly a need to enhance evidence-based upstream and downstream interventions for people who experience incarceration. So I'll maybe just say a few things that other people have published. This is not my work, but it just feels a little bit anticlimactic to just share a bunch of like epidemiological trends and data that are pretty unfortunate without having like a broader discussion about how to understand this or what we might do about it. So this visual comes from an article by Paul Jadri at the Yale School of Medicine, published in Addiction Science and Clinical Practice. And this is what's called the post-release opioid-related overdose risk model, which is just sort of a conceptual model to try to understand, like, what really is it that is increasing the risk for people who experience incarceration. So we have, some of the common things that you hear a lot about are things like lowered tolerance while someone is in custody and then resuming use at a similar level that they were before they were incarcerated. But this really adds some more sort of nuance and complexity to understanding what that risk really is. So in the model, basically, incarceration is considered an underlying factor or an adverse exposure that affects risk. And then that effect is moderated by intermediate determinants. So things like, these are things that are all impacted by incarceration, right? Like having disrupted social networks, disrupted social support, potentially experiencing or exacerbating depression, anxiety, PTSD, which I'm sure you hear a lot about in the qualitative work that you do around impacts of incarceration, interruptions in care, as I said, continuity, things like that. So those are all considered intermediate determinants or mediators. And then there are, of course, proximate determinants or outcomes of opioid-related overdose. So proximate determinants of overdose could be things like lack of access to care and treatment, solitary use, so people using alone, which of course was exacerbated during COVID-19, barriers to naloxone or other things that might help reduce risk. And then finally in box 4, they discuss some of the biological effects. So things we've heard a lot about, like lowered tolerance and things like that. So yeah, it's just, I think that things like this are just helpful in terms of trying to have a more nuanced understanding of what's actually going on and what we need to do about it from sort of a policy and practice perspective. One of the things that has been researched quite a bit is the utility of things like opiate agonist therapies. So Anne Buckton and Marianne Stausitz from Norway recently published an article in the Lancet Public Health talking about the provision of opiate agonist therapy while in prison and demonstrating that it is quite crucial in reducing mortality for 6 months after release. And they're, really pushing for that to be available to all people in prison who have treatment needs associated with opioid use. Christelle McDonald and colleagues, again, in Lancet Public Health, also recently published a systematic review and meta-analysis, and again confirmed the evidence around opiate agonist therapy, both within custody, but also ensuring in the days and weeks after release that people have access to OAT as a way to reduce deaths. They also found evidence in support of therapeutic community interventions, which is something that I'm looking at more in my work, to reduce rearrest, to reduce reincarceration, and ideally to reduce reincarceration. And then finally, a Canadian study that was recently published by Dr. Kate McLeod and colleagues based in British Columbia, who also found that receipt of opiate agonist therapy in custody was associated with a reduced hazard of non-fatal overdose, which was quite significant, and found that for prescriptions continued from community and for episodes of OAT initiated in custody, that holds true. So they also found that the effect of that was greater for women than for men, which is kind of an interesting finding. So, okay, so I'm going to stop there and happy to take any questions. I just want to acknowledge I had quite a few co-investigators and co-authors, an amazing statistician on this project who can do things that is really difficult for me to even wrap my head around, all of the people with lived experience who were involved in our consultations, and happy to provide a link to the overall summary. We were supported in those engagements by two amazing people that work for Amplify Engagement, and then, of course, the funder, Chris.
Thank you. Thank you very much. Yeah, it's interesting and discouraging and all those things. So I'm just going to open. I have a couple of questions, but I'll just open it up to other folks. I'm sure that people have questions, comments. So. Is that Mansa? Is that a hand? Yeah, please.
Yeah.
Mansa.
I was looking for the icon at first, and I said, okay, maybe I'll just raise my hand. But thanks for your presentation. I think it's definitely an important study you're doing, especially in this current climate that we're in with COVID. I was wondering if you can perhaps elaborate more on perhaps are there any theoretical reasons as to why when you were talking about the gender differences with the male and female exposure to COVID and incarceration, why there was 50% more for male and only 21% more for female? Or perhaps any theoretical reasons behind that finding that perhaps played a factor in the outcome?
Yeah, it's a really good question. So part of the reason for women having like such a stark difference in risk is that women in the general population are not dying as frequently. So just when you compare people who go to custody across the board, women tend to have much higher and more severe clinical complexities and other needs. So as a general rule, women tend not to be incarcerated at the same rate as men. And so it's sort of true across the board that women who end up in custody tend to have much higher and more complex needs. In terms of the impact from COVID, I don't have a great theoretical rationale for that, like why we saw such a major increase for men. I don't know if it's that women tend to have more or stronger or more robust social supports, or whether women just tend to be able to sort of like meet their needs in a time of crisis in a way that men aren't. I don't really know, because obviously the restrictions applied to everybody, and so while I expected for certain the incarcerated population to be more impacted, especially because there was this period of pretty quick decarceration in Ontario because of COVID, so a lot of people were released really quickly and without the support. So not like even at the best of times, the community supports are bad, but then you release them all at a time where all of those community supports are scaled back. There's a lot of things not happening in person. But I'm actually really curious whether anyone on this call who specializes in sex and gender, which is actually not really an area of mine, would have some theoretical ideas for why there was such a difference in the COVID-19 impact between men and women. I'd be really open to that. I don't have a good answer, but it is a great question.
Thank you. I think Leanne, you have your hand up there.
Hey, thanks, Kevin, and thanks so much, Amanda, for this amazing presentation. I just wondered about two bits of information. You may or may not have captured it within your study, but I was just wondering, in terms of your first study, by chance, did you examine whether the length of incarceration impacted on the death rates? And in terms of whether the persons who were later identified as having suffered from opioid-related deaths, whether they may have developed substance use disorders within prison, or they came with it, they had a history of drug use. Thanks.
Yeah, it's a really good question. Unfortunately, unlike the data that we have here in BC, with Ontario, we actually can't ascertain diagnosis upon entry to custody. We really don't know whether they came in with an opioid use disorder or whether that was developed in community, or we don't. And I actually think it's really important because from a sort of policy and practice perspective, I think the screening and ascertaining that diagnosis is so critical because the time in custody, especially at the provincial level, is so short. So our average days in custody, so median days in custody for our whole population was 41. And then our mean days in custody, length of stay in custody, the median was only 18. And then the mean was 75 for their length of incarceration. So when you think about what kind of impact you can make with somebody in like a couple of weeks or a month, it's fairly limited, right? Especially if somebody has complex needs. But what you might be able to impact is really that screening, that assessment, trying to get somebody diagnosed, get them stabilized, and then ideally connected to care for when they're in community. But we don't have an answer to that second question. And then in terms of the first question, no, we didn't look at whether there were differences in the risk exposure based on how long their incarceration stay was. But for most people, they were quite short. I think where something like this would be really important would be if you're also looking at federal custody. So that's the other thing, is our sample is only provincial custody. So people sentenced to less than 2 years, and most of them are sentenced to much, much lower than that. So where you might get longer stays is somebody who might be on like remand for a murder or something, and that could be a multi-year stay. But by and large, it's pretty short. But I think that would also be a really important thing to look at, is does the length of stay impact the risk? And my sense is that what I've seen from other studies is that it's like the shorter recurring stays that tend to really exacerbate the risk, those sort of constant short-term disruptions in people's lives and care that can be particularly damaging. So yeah, good question.
Excellent.
Questions. Yeah.
Alex, you had your hand up, or was it answered, or?
Yeah, as you were explaining, I got my question answered. Yeah, I'll keep thinking of stuff, but yeah, you did a great job answering that.
I'll go Phil. Oh, Phil, and then Sandra.
Yes, thank you so much, Amanda. It's been fascinating listening to your talk, and great data as well, like the linkages between like the incarceration corrections data and the coroner data. So evidently, based on your work, like the release time like impacts the risk of opioid toxicity deaths. So release time matters, but do you have access to the data or have any speculations about how like the risk of opioid toxicity deaths might vary by like correctional institutions or like the community that they're released in? Not every prison's the same. The programming can be different across prisons, the different structures of the prisons, and this could kind of signal maybe like a potential spot of like intervention, like where people can kind of prevent the risk if there are differences across institutions. So just wonder if you had any data or speculation on that.
Yeah, we don't have data. They didn't give us that. The other complication with that is that people often go to custody very far from their homes. So we would need to consider like is the problem the institution, or is it where people are released to? Because people just get moved around all the time and might be really far from home. There is, I believe, a team of people in BC that are doing a major study right now looking at geographic differences in deaths, and so we might get some answers from that. I speculate that, that what we hear from folks is that there are exceptional challenges in rural areas, where the access to care is so limited, access to things like naloxone and pharmacies and getting oat. And so for anybody, particularly people who are looking to maintain that continuity, it can be a real challenge, but we can't speak to the institution level. I hope that one day we'll be able to, and especially because of what we heard from our consultations around just how varied the access and quality and timeliness of care is. That was a surprise to me, because we have a bit more consistency here in BC with it being one provider. So Correctional Health Services is the agency under the Ministry of Health responsible for all care in all provincial custody. That's not to say that it doesn't differ a bit, because there are places where there's like practicalities, but like the models of care are consistent. So I was really surprised to hear some people say like, I couldn't get out, and then others saying, oh, it was like pretty good, so some real problems going on in Ontario corrections for sure.
I have a list. I have Sandra and then Daniel.
Okay, thank you so much for your talk. I really enjoyed hearing about your findings. In Alberta, Correctional Health Service is also responsible for the health service in prisons, and actually we don't see a continuation of care into the community. So it would be interesting to maybe talk offline at some point about the differences between the two provinces. But I actually have a different question. So we're currently spending a lot of time in prisons across this province. And I think our team has noticed across the board a significant reduction in drug poisonings on the units in comparison to before the pandemic, when we also did research in prisons, and we saw often multiple drug poisonings per week on the different units that we were on. And I think this is likely due, in part anyways, to the introduction of body scanners that kind of help keeping the substances out. And so I don't know if your data might be able to address this, but I do wonder whether we'll see a sharper increase in poisonings post-incarceration compared to the pre-body scanner times. I don't know if you have any thoughts on this, whether your data can speak to that, or what do you think about that?
Yeah, I really can't. I can't speak to that, and I don't even know what's happening with body scanners in Ontario. It wasn't even really something that came up. I think we're hearing a bit more about that, like in federal custody. And I spend some time every month in one of our provincial jails, and they're definitely doing a lot more around like drone prevention. They had some really interesting ways that people were getting like contraband into custody that they're cracking down on. And I do know that there have been definitely more efforts around training and naloxone access and making sure that people can respond to overdose. So we are still seeing deaths, but a lot of that now in this moment is actually benzo withdrawal. So it's just like as the drug supply becomes more poisonous and in different ways, we're like having to figure out what the issue is now, because it's actually not just fentanyl, because we have a pretty good way in some circumstances responding to fentanyl, but then there's other drugs that are, unfortunately making that intervention not so effective. But I really don't know. That would be something really interesting to explore. Is that just like is that a Canada-wide thing, this body scanner initiative?
That's a good question. I don't know. They were introduced in all the provincial prisons in this province anyways, post the pandemic. And that has really, we can just say from the being on the ground, it has really changed the dynamics in the institutions in comparison.
In a good way.
Well, that's the question, right? According to your data and all the research we know, the chance of drug poisoning is greatest post-release, as you just said. So if people are becoming sober, maybe forcefully sober in prison, then paradoxically, I think the introduction of body scanners might actually increase the chance of drug poisons after. So, I mean, that's something to think about.
Yeah. And we don't have a great post pandemic period in the data that I'm showing. There is an update coming, but because our data only goes to the end of 2020, we only have not really even a full year of pandemic in our data. So it will be interesting to see from then until, 2024, whether those patterns have changed. Yeah.
Okay. Well, thank you.
Thanks, Sandra.
Daniel.
Thanks. Hi, Amanda.
Hi.
I really appreciated your talk. It was fascinating. I'm not the most quantitative person in the world, but I really appreciate how accessible you made reporting your findings to qual folks like me. I was wondering if you could tell me a little bit more about those like knowledge gathering and knowledge translation sessions that you had done and that you had mentioned in the first study. You had mentioned, that some folks had responded saying that they had pointed out a need to address criminalization and enhance treatment and harm reduction in custody, provide safe housing release. And I'm super fascinated by all of that. I'm curious if you were able to do any of those for your COVID study, the second COVID study as well, and if any of those findings had changed or if anyone reported anything different with COVID. And also, I'm curious how you went about selecting the folks that you spoke to.
Yeah, that's a great question. Maybe I'll actually, I can give you the link to this, but I'll just share it briefly. So we do have a summary document that compiles some of the, are you seeing my share screen? What's happening right now?
Yes.
You are?
Yeah, absolutely.
Okay, I'm not. But you're seeing refining the story of incarceration opioid use? Okay,
Yeah.
sweet. Great. So basically what we wanted to do was figure out a way to have some meaningful engagement with people that went beyond just like this epi discussion. So we actually had a lot of chat about like, how do we engage people with lived experience in a project that's like so quantitative and, highly statistical. I think it's a lot easier for me to wrap my brain around more community engaged and qual projects. And so for this, what we did was we recruited via a few different means. Actually, we reached out to some community organizations, John Howard Society, Elizabeth Fry. We advertised our recruitment materials on LinkedIn. We sent just to like personal contacts for like people who are working in corrections. So we had a few different ways that we advertised. We basically just put together a flyer that outlined the honorarium, and we held a series of 3 workshops. And the workshops actually involved us. The first one was really just like getting to know each other, getting to know the project, and providing like a very, very plain language and accessible description of what we were doing. In the second workshop, we actually provided some of the data around what we were seeing in a way that was accessible, and just asked for some feedback basically into how we might interpret it, how we might display the data. And then in the third workshop, that was focused on implications and knowledge translation. So talking to people with lived experience about like, now that we know this data, what do you think we should do? Who needs to know this information? We ended up preparing just like a white paper, a 2-pager that we provided to community that might want to use it for advocacy purposes and things like that. So definitely a different kind of KT exercise than I've done in the past. And we did this with the support of 2 people who do a lot of community engaged work. So I can send this to you, and it just summarizes the data that we provided and some of the conversations that we had and some of the feedback that they gave us. Unfortunately, we didn't repeat this for the COVID study, but people still talked about COVID because of when we did this. So the COVID study wasn't yet happening. This was focused on the very first burden of opioid toxicity study, but people still like mentioned COVID, but we didn't have the funding or the ability to sort of repeat this process for the second study. But I'm happy to share this with you. And like I said, it just summarized some of what we heard around violence, like the higher risk at release, people explaining from their experience why that might be, and then summarizing like some of the organizations and people that might need to be engaged. I might actually just need to edit this one because it might have some personal information, but I'll make sure that I can get a link to you that's for public use that doesn't have the list of people that were involved, and happy to even chat later if you have more questions about doing this kind of an exercise for a more quant focused study.
Awesome. Thank you.
Yeah.
Appreciate
Excellent. I mean, we're coming close to time, but Dari does have one question. I think it's a fairly quick question. So, Dari, do you want to sort of jump in?
I'm not in a rush, so I'm happy to.
Yeah, for sure, for sure. Yeah, thank you so much for your presentation. Made so many things clear to me. But I was just very curious if there was any data available and used in the analysis of people identifying as neither male or female, so non-binary people.
Yeah, so there is some data that we did not feel was reliable. Unfortunately, every person in our study gets lobbed into one or the other, but there is another screener that will ask somebody whether they identify as one or the other, but for a lot of reasons, we actually didn't trust that data. So you'll see in our publications that it's one of the very unfortunate limitations of the way that correctional data are organized, that people are put into male or female, but there is a very, very small subset of people who did indicate being non-binary. Unfortunately, those numbers are way too small for us to have been able to do anything with it for the purposes of these analysis. But I think it's a really, really important area of future consideration for sure. Our cell sizes for this would have been far too small for us to do anything meaningful with the data. And we also don't necessarily trust it. So there's work to do. Yeah.
Excellent. So thank you. Everyone join me in thanking Dr. Butler. Thank you very much. That was excellent. For those of you, well, for everyone, we have these kind of sessions once a month, and Sandra's going to remind me who is up next month. Do you remember offhand?
Yeah, so our next speaker will be Elijah Anderson from Yale University. So that will be on October 25th. I believe that's the Friday, 12:30, same time. And everyone is welcome. Obviously, you can invite your friends and people who might be interested to hear Eli's talk.
Excellent.
Thank you so much, Amanda.
Great. Thanks, everyone. Thanks for your questions.
If Bremily could hang around for a second, that would be great.
Thank you.
Thanks, folks.